Good evening. I'm Dr. Sarah Slocum, and I'm a consultative psychiatrist here at Exeter Health Resources. I want to welcome you to our Trauma Informed Care 101 talk. This is really the foundational lecture of our multi-part series on trauma informed care across our organization. Thanks for joining us. We're really hoping to use this time to help you reframe how you think about trauma and how you think about trauma informed care. Our goal with this is to talk about not only how we treat our behavioral health patients, but also how we treat every patient in our organization, our colleagues, and even sometimes our family or friends. We want to start with how we define trauma. We should be thinking about trauma as either one event or a series of events that has a lasting impact on someone, including affecting their function, and it is typically something that they have felt to be life-threatening. What we're hoping to do is empower patients to overcome this trauma. And we'll talk about how we do that in a little bit. In order for us to all understand trauma, let's go back to how we measure trauma in people. And we're going to start with how we measure trauma in children. So a few decades ago, there was a study that started called the Adverse Childhood Experiences Scale, or ACEs. This scale looked at 10 fundamental questions. 3 of those focused on abuse, physical, mental, or sexual. 2 of them focused on neglect, and the other 5 focused on the state of the household, including whether the child was a witness to domestic violence, whether they had a relative who was incarcerated, using substances, or mentally ill, or whether someone in the home had been separated, such as by divorce. What we saw from this study and its outcomes was that at least 25% of the US population had 3 or more ACEs, and 62% had at least 1. We have to keep this in mind because there is a trauma response in all humans, and that trauma has a lasting effect from childhood through adulthood. So, we know that many people experience childhood trauma, but how does that tie into the adults that we see? What you can see here is a picture detailing how those childhood experiences impact someone's social, emotional, and cognitive development. This can lead to the adoption of at-risk health behaviors, eventually leading to disease and even early death. This ACE effect is long-lasting. So to further explore this, we know that people who have ACEs in childhood are more likely to develop certain health conditions down the road. In fact, people with 4 or more ACEs are 2 to 5 times more likely to develop a number of conditions, including suicidality, substance use disorders, mental illness, and a variety of chronic conditions such as COPD, and even to have heart attacks and strokes. The behaviors that this causes includes a lack of physical activity, an increased rate of smoking, of substance use, of alcohol use, and an increased amount of missed work time. Importantly also, these patients are more likely to be severely obese, to have broken bones, and again, to have chronic health conditions like COPD, strokes, and heart attacks. So to provide more details on how these diseases specifically relate to ACEs, we have a chart showing the number of ACEs compared to a variety of health conditions. And you can see that for a lot of these conditions, including heart attacks, COPD, and even cancer, there is a significant increase in the odds ratio with the number of ACEs someone experienced, with 3 and 4 leading to a higher risk across the board. There's also a correlation between number of ACEs and total odds of ever having a suicide attempt. This ranges all the way up to those persons who have more than 7 ACEs in their history, with almost a 20-time risk of a suicide attempt across the lifetime. Here we can see how the number of ACEs someone has experienced relates to their risk of developing depression. And what we see is that someone who has more than 5 ACEs in their history has an increased odds ratio of developing depression at some point in their life. To build on this, people have a higher risk of developing HIV with higher number of ACEs. We're not quite sure whether this relates to increased risk of substance use, increased risk of STDs, or other at-risk health behaviors. Now, let's try to bring this together. People experience traumatic events, and that leads to a specific change in their behavior, which eventually impacts their health outcomes. This trauma response affects multiple domains. Physiologically, we experience an increase in biomarkers. that cause a change in our allostatic load. We'll talk more about that later. This also has an impact on genetics, both of that person and potentially of future generations. Some people are primed to experience trauma in a certain way based on the genetics that they've inherited over the years. We also, when we experience trauma, have a change to our own genetic code that gets passed along to our offspring, our children, our grandchildren, even multi-generations down the line. Further, we should talk about the social and environmental context that trauma occurs in. For instance, people who experience trauma in a shared collective, like natural disasters, have a different response to that trauma than others. Let's shift gears a little bit and talk about the way that people experience stress. Not all stress is traumatic, but all traumas create some type of stress. There are three main types of stress. Some stress is positive. That's good stress. It's needed to help differentiate within childhood development, to help children develop their own personal style and the way that they're going to cope with things. There's also mild stress. This is stress that people experience, sometimes in their everyday life, that is still relatively benign. People can cope with it. They will return to normal without significant long-lasting impact. However, there is such a thing as chronic stress. This stress is bad. It results in someone experiencing fight or flight all the time. Can you imagine feeling like that all the time? Some people exist in that state perpetually. As such, they can be keyed up, they can be irritable, and we may see the outcomes of that behavior in our everyday work and life. Let's take a look at the brain and what's happening inside it during this. On the left, we have a brain that's had normal development. And what we see is signals that are going to the cortex or the outer part of the brain. That leads to the development of all kinds of things. For instance, these brains develop a sense of embodiment. They have a good sense of where that body is in space as well as in time. So you feel grounded to where you are and when you are. This also allows motor planning and agency, which is that sense of control that lets the body know that it's going to do what you've asked it to do. Further, there's the development of abstract thought. In the course of normal development, we develop abstract thought. Abstract thought is our ability to think about situations slightly differently. For example, if we wanted to examine a watch and a ruler and how they may be similar, someone who doesn't think with abstract thought would say that they both have numbers. Whereas someone who has had the development of abstract thought would say that those are both ways to measure things. One measures time, one measures distance, but they're both measuring something. This is key in the development of a healthy brain. In addition, there's also the development of emotional regulation. That's our ability to experience emotion and act on it appropriately. On the right side of this slide, you see a brain that's been exposed to trauma. That trauma can stop these pathways from developing, leading to a number of things, much the opposite of what we talked about on the left. For instance, these patients can be dissociated, meaning that they lose track of where they are in time and space. They may not be able to control their motor responses to different things. They may have inflexible thought or black and white thinking, that something is all good or all bad. Similarly, they may also have bad emotional regulation. Sometimes we call that emotional dysregulation. It's where someone can't quite control how their emotions impact their behaviors. Here's a different way to envision the brain. On the left, you can see a PET scan, which is a certain type of neurologic scan that looks at activity in the brain. You also, in the circles, can highlight the anterior parts of the temporal lobe. That's the part of the brain that's really responsible for emotional development and regulation. You see in this slide that in a healthy brain, those areas light up greatly when exposed to this type of study. On the right is the brain of someone who was traumatized. Those areas in this brain are dark. They're silent. They're not lighting up because the brain has not formed the connections there that were needed in childhood. Now that we've talked about what's happening in the brain, let's talk about what's happening in the body. This is that term allostatic load that we mentioned earlier. An allostatic load is really looking at three things. It's looking at biomarkers, which are certain measures that we gain from the body. Things like urine cortisol, which is a hormone that's secreted in stress responses. adrenergics, which is basically the way that we measure our fight or flight response, and telomeres. Telomeres are genetic material at the end of the chromosomes that end up being shortened with toxic stress, and that can lead to premature aging. We can also look at clinical measures like vital signs that we're measuring in patients every day. Blood pressure and heart rate can increase with any type of stress response. And things like body mass index, which is a ratio of our weight to our height, can be low in conditions like anorexia or high in conditions like obesity. We can also examine direct lab data, things like lipid profiles, which can become deranged again in obesity or in certain other types of illness. And we can look at the hemoglobin A1C, which is a marker for diabetes. Now that we've talked about the brain and the body, let's talk about how that impacts development. On the left, you see the triangle for normal development. The markers and measures for survival take up very little space. Those are things like Maslow's hierarchy of needs: housing, shelter, adequate access to food, and hydration. Those should be givens in someone's developmental pathway. That then allows that person to go on and develop good regulation of their emotions and their body, and then further, their social, emotional, and cognitive development. In brains and bodies exposed to trauma, this whole pyramid flips. Someone's needs for survival take up a huge amount of time and effort. Then someone has to focus on regulating on top of that, leaving very little time and energy left for social, emotional, and cognitive development. So let's bring this all together and imagine some types of patients who may present with these types of traumatic histories. On the left, you can see a patient who may have high or low levels of arousal. They might misinterpret social cues and have somewhat odd behaviors. They also may not be able to see the consequences of their actions and may describe feeling numb or detached. A patient may also present with chronic levels of irritability and what we call a disturbed attachment pattern. That may mean that they're very clingy. It may also mean that they don't want to attach with anyone at all. They can be disorganized or even perfectionistic, which can be seen as very demanding to a healthcare team. Patients could also present as being easily overwhelmed. They may have very negative views of themselves or of others, or both. This can make it difficult for them to process positive memories or positive thoughts, leading to them only focusing on the negative all the time. Now that we've talked about the symptoms that a traumatized patient can present with, let's talk about what our interaction with an ideal patient may look like. Our hope is always that these interactions are open and truthful, that patients and staff are respectful and polite, that there is a curiosity, but not a know-it-all type of patient. We want patients to be willing to learn and motivated for change. Additionally, our hope is that they're reliable and compliant with recommendations that we make. What do we see in a patient who's traumatized? We actually see the opposite. Because of their trauma history, they may present again as demanding or feeling like they know it all. They may try to direct their care, and that can be something that the care team doesn't always appreciate. Having a knowledge of how these traumatized patients can present in a clinical setting helps us recognize those and take next steps towards helping them and also avoiding re-traumatizing them. This is really how trauma-informed care helps us care for these patients and also interact with other people in our life. First and foremost, we need to understand trauma and the paths for recovery. We then need to be able to realize how to recognize how these symptoms present across a variety of different settings. Integrating this knowledge into our practice helps us resist re-traumatizing patients. This is really important. A lot of us have already taken something called the Hippocratic Oath. One of the tenets of that oath, which is required of physicians when they graduate from medical school, is to do no harm. Actively resisting re-traumatizing patients is really holding up that tenet to do no harm. What we want to improve with this is patient engagement, treatment adherence, health outcomes, and even provider and staff wellness. In essence, we're trying to shift to the paradigm as described here. We often focus on what's wrong with someone from this desire to fix them. What we need to shift to is more of a thought process of what happened to you. That question of what happened implies a curiosity and a need to know that helps us explore what that trauma may be for a patient. We can then further move to the right into a paradigm of what do you need and how can we help you achieve that? That need to connect and the ability to create a relationship with a patient despite their trauma history is how we help them move forward in recovery. To achieve trauma informed care, we really look at 6 tenets that can help you frame your patient's history in order to help us all achieve these goals together. We're going to talk about each of these in turn. First and foremost is safety. Throughout the organization, our patients and our staff need to feel both physically and psychologically safe. Psychologically safe may be a new concept for some of you. So to further explain that, let's think about this. We think that every patient and every staff person should have the ability to speak up in meetings, to raise innovative new ideas, and even to talk about concerns that they have without a fear of retribution. In order to cultivate this safety, we need to understand and avoid potential triggers of the fight or flight response. These include things like not feeling listened to, having a lack of privacy, which can be a problem sometimes in double rooms. We also frequently encounter patients when they're in a vulnerable physical position. Staff people are frequently standing over the patient or huddled around their bed while the patient is seated at a lower level. That can cause patients to feel physically unsafe as well. Staff people sometimes are using a louder volume, either from concerns that a patient is hard of hearing or simply to make themselves heard. Patients can also feel isolated, and that can lead to an unpredictability in their responses. Sometimes staff can be perceived as being authoritative or pressuring or blaming a patient for their condition. We also have to be mindful of the gender of staff versus the gender of a patient. Some patients feel uncomfortable with staff persons of a certain gender. There can also be a sense of embarrassment that's prevalent in these interactions. As we saw earlier on the schematic of the brain, traumatized patients struggle with disorganization. This disorganization can lead to problems with processing, with their memory, and with their stress response. We need to actively try to calm these feelings before and during our interactions with the patient. There are many steps that we can take to help a patient achieve and maintain calm. The first one here is my favorite. It involves speaking in a low and calm voice. It's sometimes natural when you're faced with a patient who's loud to want to raise your own volume. The problem with this is that it really raises the patient further up to your level. Instead, if you can talk at a calmer and quieter tone, the patient will naturally calm down and become more quiet so that they can hear what you have to say. We can also take a step back and take a breath if necessary. This also models that behavior for the patient. We can use empathy statements to make the patient feel understood. I want to note too that this does not mean saying things that are not true. We don't want to tell the patient that we've been exactly where they've been, because we probably haven't have. However, we can say things like, "I'm curious, help me understand. I'm sorry you're going through this. Let's explore ways that we can work towards getting better together." We can also practice self-regulation and co-regulation. What that really means is working on achieving our own self-regulation as a way to help that other person calm down. Again, modeling taking deep breaths, as well as modeling a quieter tone and a maintenance of our own physical space can be important there. We also need to stay connected with our patients. It's really easy to talk to someone, calm them down, and then leave their room for a prolonged period of time. We have to make sure that that doesn't happen. We really need to be checking in frequently, making sure that things are still going well, and reassuring that patient that we are following through on what we said we were going to do. Let's talk a little bit about different statements that we can use to help generate this culture of safety. We want to be able to explain what is happening to the patient, and we need to do that on a consistent basis. We also want to acknowledge that everybody makes mistakes and that this is a safe place to talk about those mistakes. We can let them know that no one is going to ridicule them here. We also need to express a hope for their future, that even if they're feeling down right now, we have hope that things can change and that we're there to talk to them about how we can start that change. We can reassure them that tomorrow is another day and that we can always try again. We can let them know that we believe in them and that they're doing their best for where they are right now. The second tenet of trauma informed care is transparency and trustworthiness. We really want to assure patients that we're making decisions in a transparent manner and with the goal of building and maintaining their trust. So, what does this look like? I want you to think about a time maybe that you have been a patient in a medical facility. Was everything explained to you? I see so frequently when I'm going into a room that we engage with patients without explaining to them what we're going to do. Even I may sit down without asking the patient if they're okay with that. I may turn off an alarm or adjust something on their bed without asking their permission. We really need to be upfront with everything, from asking to sit to administering medications to talking to them about an upcoming procedure. It's important to build that trust and hold to it, as that engages the patient and also lets them know that we're here for their best interests. The third tenet of trauma informed care is peer support. For peer support, we're really looking at engaging with individuals who have shared experience with our patients and connecting them as an integral part of our care teams. Let's think about how much easier it is to connect with someone who's had a shared experience. Think, for example, of members of the military, firefighters, or policemen, and how well they connect with their colleagues. You may think back to times in high school or college and shared experiences that resulted in a bond with your friends. In the hospital, sometimes it's hard to make those bonds with our patients. Maybe they're struggling with something that you've just never struggled with. Maybe they use substances. Maybe they have schizophrenia. Maybe they've had a horrific assault, and none of that is in your history. How are you going to connect with that patient? It's really important to take the time and find something to connect with that patient on. And if we can't find something, it's important to find a peer who can. Developing that type of relationship helps the patient feel assured that we are there for them and that we have their best interest in mind. The next tenet of trauma informed care is collaboration and mutuality. Really, this tenet seeks to take power differentials either between our staff and our patients or even between members of our organization and level those so that we can all move forward together. Traumatic events are really a cause of loss of power and loss of control. With trauma informed care, we seek to return some of that power and some of that control to our patients. We do this with statements that imply curiosity. One of my favorites is to say, I'm curious about this. Can you help me understand? That implies that you're interested in the patient's experience and gives them the opportunity to talk to you about what they've been through. Further, that allows us to brainstorm for potential solutions or alternatives that this patient can employ. Really using curiosity as your motivating drive takes the stigma away from the patient talking to you. This leads to the next tenet of trauma informed care, which is empowerment. We want to recognize the positives that patients and staff bring to the table and figure out how we can use those in an even stronger manner to move forward. Again, trauma causes us to develop powerlessness and helplessness. So, empowerment should be our constant theme. And that empowerment really happens through partnership and through relationships. That's why this is such a relational form of treatment. We want to increase someone's resilience and their own belief that they can recover from what they've been through. We need to highlight and recognize their strengths and notice that small wins are very important. We should recall that self efficacy is really the opposite of learned helplessness. This is the belief that someone can manage their own problems and that they can succeed at that. The last tenet to be aware of is cultural humility and responsiveness. This involves acknowledging that biases and stereotypes, whether they're based on someone's race, ethnicity, sexual orientation, gender identity, or age, and historical trauma, needs to be recognized and addressed. Everyone has experiences and traits, including those that we talked about, that impacts their worldview and how they're framing their life. This also impacts how they experience trauma and how they may develop symptoms of trauma. We should ask questions and again be curious about those social norms and the patient's culture. Respect and curiosity, openness to learning, Those are always important traits for our staff to have. We need to make sure that we're considering racial implications of power and the cultural context of providing someone's care, as well as staying mindful of those gender differences between parties. Chronic trauma is inherent in institutionalized racism, and we have to maintain a knowledge of that. It's also very important to note that none of this happens overnight. As we get older, our brains are less susceptible to change. So it's harder for us. It's also harder for our patients. Navigating through all of this trauma-informed care is going to take time. So don't expect yourself to be able to change overnight. We also shouldn't expect our patients to change overnight. Now, what if we use trauma-informed care just like we use gloves as a universal precaution? If we went into any interaction with another staff person or with a patient with an openness to learning, a curiosity about their background, and an acknowledgement that they may have trauma that we have never experienced. That trauma can impact their behavior, how they look on a good day, how they look on a bad day. Keeping that in mind allows us to ally with that patient or with that colleague in order to have a better impact moving forward. Here are our aspirations as we all learn together. We want everyone to be able to realize that many people bring trauma to the table. We also want to be able to recognize what those symptoms of trauma can look like in different people, and those presentations may differ. We want the entire organization to be able to respond to people and to colleagues in a trauma-informed manner. And lastly, we want to actively resist re-traumatizing anyone, whether it's a patient or staff member. So what's going to get in our way? Stigma is a big one. Stigma against behavioral health or substance use disorders, psychiatric patients, as they're so often termed, can lead to avoidant behavior. These patients are frequently dismissed, and we need to work on that. Behavioral health and substance use disorders are not medicalized as a disease. And again, improving our own knowledge of how those disorders come about can be integral to changing this. There's a significant lack of acknowledgement of trauma across the board. I bet many of you, when you came to this lecture, still considered trauma to be car crashes, gunshot wounds, and things having to do with the trauma bay or a trauma surgeon, when in reality, trauma is far more wide-ranging. We also have an uncomfortable feeling with this conversation. We're not well trained with how to have this, and because we don't have the vocabulary backing us up, it can make it very difficult for our staff. Sometimes we fear it may offend the patient. We don't want to ask them things that make them feel uncomfortable after all. Some people feel Pandora's box. If I ask this question, what am I going to do with the answer? I've had many clinicians come to me over time to say, I never ask anything if I don't know what I'm going to do with the answer. But this is a situation where we do need to maintain curiosity because otherwise the patient isn't going to volunteer this information. We do have a lack of resources. That has to be acknowledged, but we're working on it. So don't let that hold you back from having these conversations with your patient. We'll work really hard to help find support for them, whether it's here or in the community. This can sometimes also be construed as a political correctness agenda or as training to just be nice. I hope that you know by now that this actually goes far farther than that. We're really hoping to, again, identify trauma and learn how to recognize the symptoms so that we can improve patient care. Now, let's go all the way back to the beginning so that I can tell you what I really need you to understand. We have to know that our patients come to us with certain events in their history that may have robbed them of their control and their dignity. These events, in the setting of an individual's experience, which includes their culture, their history, their genetics, and other factors, can lead to certain effects. Those effects can be biological, psychological, again, even genetic. By acknowledging this equation and recognizing the symptoms of trauma in our patients, we can improve healthcare across the board. Trauma-informed care means different things to different people. For some of us, being a trauma-informed clinician comes naturally. We're just good at it. Maybe we've always been this way. Maybe we've had prior training to help us along. For others, trauma-informed care can be difficult. It may be that we have our own trauma in the past that impacts how we're interacting with others. Maybe we've just never had training on it. It can be uncomfortable. Let me leave you with something to think about. The core experiences of psychological trauma are a disempowerment and a disconnection from others. Recovery, therefore, is based upon empowerment and the establishment of new connections. Recovery can only take place in the context of relationships. It can't occur in isolation. My hope is that after hearing this lecture, you feel better able to acknowledge trauma, recognize it in others, and assist them in their steps towards recovery. Thank you very much for your attention.